Greetings and welcome to Addressing the COVID-19 Crisis, an open forum webinar series for pharmacists. It is good to have you with us again this week as we discuss late-breaking news and information for your practice. I'm Michael Hogue. I'm the Dean of the Loma Linda University College of Pharmacy and also the President of the American Pharmacists Association. On behalf of APhA, we want to extend our thanks and appreciation to all of America's pharmacists for the outstanding work that you're doing in caring for people in your local communities day in and day out. We've got a lot of great information to share with you today, and we know that you all will have questions as well. Today's topic is going to be three representatives from the FDA's Center for Drug Evaluation and Research, who will be providing an overview on compounding, including how it relates to drug shortages. Now, our three speakers that we will have today are first, Gail Bormel, Acting Associate Director for the Compounding Program in the Office of Compliance. She's both a pharmacist and a lawyer. She leads the inspection, policy, and outreach efforts related to human drug compounding and has been with the FDA since 2003. Gabrielle Cosell is the acting senior advisor for compounding and leads significant stakeholder engagement initiatives and manages research and policy initiatives on drug compounding. And Ian DeVoe is the acting division director in the Office of Manufacturing Quality and the Office of Compliance. And he works to protect the American public from poor quality drug products and ensure compliance of firms authorized under sections 503A and 503B of the Federal Food, Drug, and Cosmetic Act. Now, just like our previous webinar times, we have subject matter experts from APhA's staff who will also be joining us, especially to take your questions. Dan Zlott, Vice President of Professional Education Resources at APhA, as all of you know, has a 10-year history of working at NIH as an oncology and infectious disease specialist, has lots of information about immunology. And we know we have some information this week that we'll definitely want to ask Dan about relative to some drug therapy news that came out this week. And we also this week are joined by Michael Baxter. Mike is APhA's Senior Director of Regulatory Policy, and he works in government affairs at APhA. And we're very grateful, Mike, that you've joined us today as well. Now, I just want to go over our agenda for today and again remind you of some housekeeping rules for our webinar. You'll notice on the right-hand side of your screen at the GoToWebinar control panel that there is a tab that says Handouts. Under that tab is the PDF copy of today's slides. We would encourage you to reference that, and you'll have it available to you after the program. I also want to remind you that we are recording today's program. It will be available to you. It'll be emailed out to the program attendees, but it'll also be available at pharmacists.com in the COVID-19 webinar or the COVID-19 information section on pharmacists.com. So be sure to refer your friends there if they'd like to follow up on the content of this webinar after the webinar is over. Also, as a reminder, you'll notice that there's a poll where you can chat and ask questions. We do want you to go ahead and type in your questions as you have those come to your mind during the webinar. And if the speakers don't address the questions at the moment, we'll have time a little bit later in the webinar when I'll be able to open your line and allow you to ask your question verbally of our presenters today. Now remember, your questions can be on any subject related to COVID-19. You're certainly welcome to ask questions about the topics that the FDA is going to be discussing today, but you can ask any other question that you'd like to ask about COVID-19 as well, and APhA's experts on this topic will be able to share with you the information that we have available. And so, as you can see, we'll spend a little bit of time here at the front talking with our FDA representatives, led by Gail Bormel, and then we will talk a little bit about your questions and have some discussion for that. So it looks like it's going to be an exciting webinar today. Let's jump in and get started. Gail, Gaby, and Ian, welcome to the webinar today. Can all of you hear us?
Yes, this is Gail. I can hear you.
Wonderful, great, and we can hear you, Gail. And thank you to you and your team for joining us today. I really want to, first of all, just express to you appreciation for the speed and attention that FDA has been providing for compounders to help fill urgent needs and to ensure that drugs are available and accessible to patients, whether it's in response to a drug shortage or a supply disruption. I think to get us started out today, Gail, if you don't mind, I use the terms 503A and 503B as I was introducing one of your staff members today, and I don't think that all of the pharmacists on our webinar today are directly involved in compounding. Could you give us just a quick refresher on the difference between 503A and 503B compounding, just to kick us off?
Of course. Section 503A, that refers to the part of the law that describes the compounding by state licensed pharmacies, federal facilities, or licensed physicians. And there's specific conditions that allow that compounding to be exempt from certain other provisions of the law, namely the provisions that require new drug applications, adequate directions for use, and CGMP to be followed. So the 503A refers to the state licensed pharmacies that are compounding drug products. And basically, just to go over some of these conditions, the compounding has to be done pursuant to a patient-specific prescription. So we have the triad relationship, the pharmacist, the physician, and the patient relationship. Compounding pharmacists have to use certain bulks when they compound drugs. They can use components of FDA-approved drugs. They can use bulk drug substances that are subject to USPNF monographs, or they can use bulk drug substances that are on a list of bulk drug substances that the agency has reviewed and placed on a list to be used by 503A, state licensed pharmacies and compounding. We call that the 503A bulk list. There are a couple other provisions, but those are some of the main ones. There's, different. One of the ones we'll talk about today is a provision against copying regularly or in inordinate amounts copies of commercially available drug products. So, there's sort of limits on all of the compounding that a state licensed pharmacy can do under 503A. We'll turn to 503B, that refers to Section 503B of the Act. And that pertains to compounding by outsourcing facilities. And this section of the law was put into place in 2013 by the Drug Quality and Security Act. And the outsourcing facilities are more similar to conventional manufacturers in that they must follow CGMPs. They're required to adhere to it. They don't need to have a patient-specific prescription, although they could compound pursuant to a patient-specific prescription. They also register with the agency, and they submit product reporting to us. In addition, they submit adverse event reports to us. They're required by law to do that. So those are a couple of the high-level differences between what we call 503A, state licensed pharmacies, and 503B, outsourcing facilities.
Okay. Well, that's very good. Good foundation for us to start with. Now, I'd like to really jump into COVID-19 now. What are some of the most significant drug shortages related to COVID-19 management that you are seeing in the inpatient hospital setting that compounding pharmacists could address?
Well, we're primarily seeing shortages related to treating the COVID-19 hospitalized patients. And you'll notice the types of drugs we're seeing on our Appendix A of the 2 guidances that we've issued regarding compounding. And these are drugs that are IV solutions used to maintain people on ventilators. You see drugs like midazolam and other sorts of drugs, vercuronium and other drugs that are being used to maintain patients on ventilators. And, we're seeing that's Appendix A drugs, which we'll talk about a little bit later, but you can see from our FDA shortage list that we're seeing a lot of other types of drugs. You know, obviously propofol, another drug that's used for the patients in ventilators. But I think we're expanding to see other types of drugs too as this pandemic progresses. I think something that's notable about this particular coronavirus issue is that we're seeing shortages that vary regionally. So a lot of times, you know, we may see regional shortage, but we see it particularly in different areas. And I think that it has to do with, you know, the resources that are being devoted to those hotspots to treat patients that are hospitalized with COVID-19. And so as we see those resources go to certain hotspots, we see other parts of the country that can't get certain approved, FDA-approved drugs. And so you see a lot on shortages.
Yeah, well, that definitely seems to be what we've been hearing from pharmacists. Now, are there any observations or concerns from FDA regarding the compounding of these products? So if hospital pharmacists are engaged in compounding these products, what observations or concerns do you have about that?
Well, I think what we've tried to do is lay out in our guidances, which you'll hear more in depth from Gaby and Ian later on, is we have an approach to how compounding can be used to help some of these shortages. And specifically, we've issued guidances that provide discretion for outsourcing facilities to compound these drugs that are used to treat hospitalized patients with COVID-19. And we've listed drugs in Appendix A. And then if the outsourcing facilities are unable to provide the supply needed, then we are looking to the state licensed pharmacies to provide those drugs and to you know, provide them in the manner that is described in the guidance, which we'll go over. But basically, there's some record keeping involved. There's beyond use dating restrictions that are involved, and you know, a couple of other provisions. So, you know, we do envision that compounding can assist in providing the drugs that are needed when FDA-approved drugs aren't available, and when you know, the outsourcing facilities first they'll step in to sort of provide the supply, and then we also envision the state-licensed pharmacies also helping.
Okay, all right. Well, that was a little bit about the hospital and inpatient setting. Can you comment on drug shortages in the outpatient or community setting in the midst of COVID-19? Are there compounding related options for those shortages as well?
Well, as you know, we have the FDA shortage list, and once a drug appears on the FDA shortage list, we would consider that that drug is not commercially available for purposes of the law in Section 503A. So what that means is that a compounding pharmacy, a compounding pharmacist in a state licensed pharmacy would be able to compound drugs that are copies of drugs on the shortage list pursuant to a patient-specific prescription and pursuant to all of the other conditions that are in 503A in order to make that drug available. But when something is on the FDA drug shortage list, it means that restriction on copies is lifted. Similarly, for outsourcing facilities, once the drug product, FDA-approved drug product, is on the FDA shortage list, the outsourcing facility would also be able to make copies of that FDA-approved drug.
Okay, all right.
So what I envision happening is that as these drugs are on the shortage list, we'll see, you know, perhaps compounders start to make these drugs.
Okay, all right. Well, what communication are you at the FDA having with the states related to compounding oversight during the pandemic?
Yes, we're in constant communication with the states, with the boards, and with NABP regarding issues that arise in the pandemic. And I think that it really depends on what state you're in, because certain states are just, you know, very much affected in a negative way due to, you know, COVID-19, and so require a lot more, you know, resources, more drug supply, and some states are just not as affected. So, you know, our communications are just to keep on top of what's going on across the country and to provide clarity on our guidances that already exist. And as you know, we've issued 4 guidances and also worked on another 5th guidance to provide information that is needed across the country.
Yeah. Well, this is such a complex issue and involves so many agencies and governmental and regulatory organizations. And, you know, I think it's good to see the responsiveness. And as I said at the beginning, I think we're grateful that FDA has been engaged in this and providing compounders the ability to provide, you know, for some of these urgent needs. Now, I wonder if, Gail, I know you've prepared just a few slides for us that contain information that you think all pharmacists who might be engaged in compounding need to hear. I wonder if you'd be willing to go ahead and share that information, that presentation with us. And then when Gail is finished with her presentation, we'll start taking questions from the audience. So audience members, please type your questions into the question box, and whether that's about compounding and the FDA or whether it's about another topic entirely, please just add your questions in.
And I don't know if Ann can post the slides. I sent them.
We have them. They're on the screen.
Okay, great.
Yep.
So if you could, that's great. Oh, okay, I see them. All right, thanks. So we're going to give an overview of the 5 guidances related to compounding that have been issued by the agency in the last 6 weeks or so. And I wanted to highlight that these are guidances that are specific to COVID-19 and compounding. So that's what you're going to hear about today. If you have questions about the other guidances we've issued generally on compounding, you can always send those questions into our compounding box, and you'll have that email address at the end. But those policies are not what we're talking about now. Instead, we're highlighting the compounding guidances that we've issued to deal with COVID-19. So you can see from there on the second slide that we're going to talk about 5 guidances today. Gaby's going to talk about our temporary policy regarding personal protective equipment practices for sterile compounding. She will also talk about our compounding guidance related to hospitalized patients with COVID-19, and this would be the compounding by pharmacy compounders, those that are not registered as outsourcing facilities. And then we're going to turn it over to Ian, who will talk about our compounding guidance related to outsourcing facilities that are compounding products to provide to patients with COVID-19. And he will also talk about the guidance related to repackaging or combining of propofol. And then I will talk about the first guidance we issued back in March, and which was subsequently updated in April, which is the compounding of certain alcohol-based hand sanitizers. So I'm going to turn it over right now to Gaby to start on the personal protective equipment.
We're trying to, oh, here we go, try again.
Okay, can everyone hear me?
Yes.
Great, wonderful. Hi everybody, and thanks for having us on today. And I will start with the guidance on personal protective equipment that we released, I guess, a couple weeks ago now. So just a bit of background on this. We were, I think there's general awareness of the shortages of PPE, that are affecting the country and more broadly, generally affecting healthcare workers. It became clear to us that there was also an effect happening in the sterile compounding space, and that folks were not able to get their normal garbing that they would use when conducting sterile compounding. There were, I think, a number of efforts in this space to try to put forth guidelines from other entities outside of FDA, and there was a request made to us to speak to this as well, and in particular to explain when we would not intend to take action for violation of the insanitary conditions provision in federal law with regard to use of PPE or garbing. So we put that's why we put out this guidance. This guidance is specific to compounding under 503A, so it doesn't include the outsourcing facilities. And I'll just walk through the general approach we took. First, we shared a couple of thoughts on how compounders could remain in compliance with the insanitary conditions provision by such as by limiting compounding or limiting the personnel that compound. Generally we understand that compounders will likely be in direct communication with providers when such trade-offs, need to be made if there really is, a risk presented here, and the question is whether or not this, the compounded product is needed or can wait. But for compounding that continues without standard PPE, the guidance sets forth a number of conditions. One is that the compounder employs mitigation strategies to reduce the risk of product contamination. And then there's a few record-keeping requirements as well, that they keep records when compounding is performed without the standard PPE and when there are changes in the sterilization approach, and that they document the mitigation strategies as well. One quick caveat that the condition on the employment of mitigation strategies is slightly different. If rather, we wouldn't necessarily need to see mitigation strategies employed if the compounder is able to use terminal sterilization. So that's one of the conditions as well. But for those that can't do that, and for those that don't have PPE sufficient for normal sterile compounding and that want to employ mitigation strategies to take advantage of this enforcement policy, we also lay out a number of specific mitigation strategy recommendations later on in the guidance. And these include things like use of PPE that's past its expiry, as long as it's not visibly damaged or soiled, reuse of masks with appropriate disinfection, recommendations on storage of reused masks to promote drying. It includes recommendations on reuse of gloves with appropriate disinfection, increased cleaning and disinfection generally in the compounding space, and consideration of increased environmental monitoring to assess the effectiveness of cleaning. We also recommend limited beyond use dates of 24 hours at room temperature or 3 days refrigerated. And we also recommend, when it's available, considering use of a sterilizing and pharmaceutical grade syringe filter, so long as the product is compatible. We do note at the end that we recognize that given the exigencies of the public health emergency, that compounders may need to consider alternate mitigation strategies than those that we have described. And we just say that the compounder should ensure that such strategies are similarly protective of the product. That's sort of a high-level summary of that guidance. I guess I can move on to the next guidance, and we could do questions after if that works.
Yeah, that'll be fine. If you don't mind, Gaby, we've got about 6 minutes left for the presentation slides. So if we can move through that, we'll get to questions.
Got it. Understood. Let me just zip through this and turn it over to Ian. So as Gail mentioned, we set forth a framework for our guidances on compounding during COVID to really sort of set an expectation that the hospital are seeking supplies of an FDA-approved product first, and if approved product supplies aren't sufficient, that they then go to the outsourcing facilities before finally turning to pharmacies under Section 503A to look for supplies of drugs. So I'll talk briefly about the 503A guidance. The temporary policy provides enforcement discretion related to essentially a copy provision and the prescription requirement. And to qualify for the enforcement discretion, the compounder needs to make drugs that are described in our list in Appendix A. That's about 10 or so products. As I mentioned, the pharmacy would have to obtain information from the hospital that they attempted to obtain FDA-approved drugs or drugs from outsourcing facilities, and the hospital couldn't get those sufficient supplies. Importantly, the pharmacy has to notify the Board of Pharmacy where they're located, as well as the Board of Pharmacy where the hospital is located if that's different, and ensure that those boards do not object to the pharmacy providing such supplies. The pharmacy has to mark an order with the hospital name that this is related to COVID-19, and also request the names of the patients receiving the drugs within 1 month of provision. And finally, a limited beyond use date here as well of 4 days room temperature and 6 days refrigerated in most cases. Well, I'll stop there and turn it over to Ian.
Ian, is your line unmuted? We can't hear you.
Yeah, I was, it didn't, hello everyone, it didn't cooperate.
We can hear you now. We can hear you now.
Great. Wonderful. All right, so for the outsourcer facilities, one there is some enforcement discretion granted. Again, similar to the 503A guidance, there is Appendix A drugs, and it's the same Appendix A. In addition to that, there is enforcement discretion on essentially a copy provision, a enforcement discretion on the bulks list. And for the last bullet item, as Gail indicated, 503Bs must adhere to the regulatory requirements regarding good manufacturing practices. And one of the requirements is that before you can distribute a drug, you have to perform a stability study in order to put an expiration date or beyond use date based upon scientific data. For the purposes of this guidance and for the drugs on the Appendix A list, the agency is using enforcement discretion that 503Bs do not need to complete the study. The understanding is that they will are given a default beyond use date of 28 days, and with the understanding is that if they expect to go over 1,000 units within a 6-month period, they are to initiate the stability study to either confirm that the 28 days is scientifically supportable beyond use date, or if they wish, they can go do the stability study beyond the 28 days to label it with a longer beyond use date. Some of the conditions is that the hospital, that the 503A or the 503B have received notification from whatever hospital that they cannot acquire FDA-approved drugs. And again, as I indicated, they are given a 28-day beyond use date. We'll note that what Gaby indicated, that the default beyond use date for 503A is 4 days. 503B, it's 28 days. And that difference is based upon having to meet good manufacturing practices. Next slide, please. One of the drugs on shortages that are being used to treat intubated patients for COVID is propofol, and there's a general shortages of this. Now, the shortages are in the larger containers of it, the larger presentations, and the agency has received a lot of inquiries from practitioners indicating that they're having to either pool the smaller containers across a manufacturer, across the same manufacturer, wanting to be able to combine different propofols made by different manufacturers in order to treat these patients. The guidance provides is an examination of the approved products, the approved propofol. One thing about propofol, it's kind of a sensitive drug. It's prone to oxidation. It also is a growth promoter, and that many of the formulations, the approved formulations, have an antioxidant of some type, and they will have a microbial growth inhibitor. But they're not the same antioxidants, or not necessarily the same antimicrobial inhibitor. So the guidance provides instructions on which propofols can be combined, considering the composition of the antioxidant in the antimicrobial agent, which can be given a in-use time of 12 hours, and which can be given a 4 hours in-use time, in which formulation should never be combined with any other formulation. And with that, I will turn over to Gail.
Okay, so if we can go to the last slide, which is about hand sanitizers. Yes. So one of our earliest guidance, it was the first guidance we issued during COVID-19, was regarding alcohol-based hand sanitizer products. And basically, this guidance said that the agency wouldn't object to state licensed pharmacy, federal facilities, or outsourcing facilities, all 503A and 503B firms, making alcohol-based hand sanitizer products, because if you all remember, we had a shortage of those during the early days of the pandemic. And so what was provided was a description of the final formula that is to be used, which you can see here. It's alcohol-based, and either isopropyl alcohol to 75% or ethanol to 80% must be in the final formulation, and glycerin, hydrogen peroxide, and sterile distilled water are to be used to make this. And the compounder should not be adding any other active or inactive ingredients to either improve the smell or taste due to risk of accidental ingestion in children. And as we say in the guidance, different or additional ingredients may impact the quality of the guidance. So that's the formula. There's a lot of other information in the guidance, and I would hope that if you are making this, you would take a look at it. It has been updated in April, and so there's additional information. One of the other important points is that the hand sanitizer product should be produced as an aqueous solution. That is in the guidance, in addition to a formula to tell you how to denature the alcohol if it isn't already denatured. And we also have the labels that are supposed to be used for consumer use or for healthcare professional use for both isopropyl or the alcohol-based hand sanitizers. So I will wrap up with the last slide. If you have questions regarding any of these guidances, and I think these slides will be distributed to people, they're probably already in the chat room. Here are the contacts for the hand sanitizer guidance. That's a specific mailbox to send your questions. Regarding the propofol guidance, or if you have other questions regarding FDA-approved drugs that are being combined and there's concerns about the beyond use dates, you can send that to the OPQ inquiry box. And for the other guidances, please send the requests or inquiries to the compounding at fda.hhs.gov box. And so with that, that concludes our formal presentation.
Thank you, Gail and Gaby and Ian. We appreciate this insight that you've given us. Now, before I jump into the Q&A, I believe we have a polling question we'd like to ask you all, and ask the staff to put this up. Just your opportunity to give us some input. I have been able to address some of the drug shortages in my practice with compounded products. Tell us yes, no, or not applicable to your position. Have you been able to use compounding to help address shortages in your practice? All right, let's see what the results of our poll are today. Well, it looks like about 21% of you are. 68% of you are not compounders, so you're not involved in compounding, and 12% of you who are in that role are not currently using compounding to address shortages. Well, that's good information. Well, we're getting questions rolling in, and I'm going to go ahead and just tell you again, use the questions field on the GoToWebinar toolbar to submit your comments and questions. We already have several. When I unmute your line, there's a 60-second time limit for you to be able to state your question or comment. We'll try to get to as many of these folks as we possibly can. For those that we don't get to, I just want to call your attention to the fact that on the APhA Engage platform at pharmacists.com, there is a COVID-19 group, and we take some of the questions that we get each week that we can't get to during the webinar, and we post the answers to those questions on the Engage platform. So please visit that platform often so that you can see the answers to your questions. Now let's start out with a question that we've gotten from Kaylin Bowman, B-O-W-M-A-N, Kaylin Bowman. The question, Dan, is where is the data coming from that is generating the discussion on social media and in the media about a lack of immunity post-infection and the risk of reinfection with COVID-19. What's out there about this topic?
Well, good afternoon, everyone. Kaylin, great question. So as best I can determine, a lot of this is coming from news stories, mostly coming out of South Korea, where there are a number of news stories of somewhere in the neighborhood of 50 patients who have reportedly become reinfected with the COVID-19 virus. It's a little unclear, however, if it's truly a reinfection. If you dig a little bit deeper and find a few more of the details, sometimes it's not a true reinfection. It's just that they're testing positive for the virus outside of a normally expected window. So when someone's infected with COVID-19, on average, you can find the virus using PCR tests for about 20 days or so. So if you were, say, 27 days, 30 days out, that's a little outside of our normal window. And so people are suggesting that that's maybe a reinfection. So that's one place. If you actually look at the true clinical literature, PubMed, other Embase, other common sources of scholarly data, there's actually very, very little data available. There are a couple of case reports that are out there, and those case reports sort of fall into that same category of situations where there's PCR positivity outside of a window that was expected. And some of these come from very, very early on in the COVID-19 experience. So that's the data. So let me give you my opinion right now. I'll make it very clear. So far, I don't think there's any solid data suggesting that there is, in fact, reinfection happening. It may be happening, and it may be more common than we know. But as far as what the data and what case reports in the clinical literature are showing, so far, there's not a lot of evidence to suggest that that's, in fact, happening.
Okay, great. We have a question about compounding from Cameron Khan, K-H-A-N, first name Cameron Khan. Cameron, would you like to ask your question? And Gail, this question would be for you and your team at FDA. Cameron, your line is breaking up. We're going to put you back on mute, and I'm going to just go ahead and ask your question for you. I apologize for that. FDA staff, if we're doing compounding I'm assuming for hand sanitizer is probably where this is leading. If there's an ingredient missing, or if you're compounding something else and there's an ingredient that's in the list missing due to this lockdown, and there's a known alternative that will work, is it possible to use alternatives, or is it necessary to only use the formula provided?
Yeah, the formula is prescriptive, and to the extent that there's anything else recognized, it's in the guidance, but there's no substitution really for ethanol and isopropyl alcohol. The inquirer didn't mention which particular ingredient he or she was thinking of, but Ian is correct. You have to stay in accordance with the formula as described in the guidance. If there are questions regarding substitutions, I did put the email at the end of the slide presentation, and you could ask that directly to the COVID-19 box. I believe
Sure.
That's the email.
Great. Let's take a question here from Leslie Walthall, W-A-L-T-H-A-L-L, Walthall. Leslie Walthall, you have a question for our FDA guest today related to propofol.
Try and open her line. It's self-muted. Here it goes.
Leslie, you're on.
Hi, can you hear me?
Yes, we can hear
Yes.
you.
Okay. You provided guidance when combining propofol, and it states a beyond use date of 12 to 4 hours for hospital pharmacies. What type of containers can be used to combine the propofol? For example, can you put that in a polypropylene syringe or a plastic IV bag that it will still remain good for the 12 to 4 hours?
Ian, do you have thoughts on that?
Yes, there is potential problematic. Propofol is, again, as indicated, is a problematic formulation. The approved packaging, packaging of the approved product. And as per the USP monograph, is glass. And the reason why is that a lot of the plastics absorb propofol, so prolonged storage in plastic, many of the plastics will end up moving propofol from solution because it'll now adhering to it. So I can't give any real recommendations. I know that there's been multiple questions about that, and there's no clear study indicating which plastics are appropriate and which are not. This just again leads to the reason for the short beyond use dates and an examination on being careful which plastic. There is no clear evidence on which plastics are safer than others.
Thank you for that answer. We've got a question from Melanie Boron, B-O-R-O-N, about Remdesivir. Remdesivir has been a drug that's really been in the news this week. Melanie, how about your question? Well, I'm not hearing Melanie, so I'll ask the question for her. Dan Slott, how about in just a short period of time, give us a real brief update on what the breaking news was this week about Remdesivir. Can you give us that update?
Absolutely. Melanie, this is a topic that we've gotten a lot of questions about. So this week, there have been 2 randomized controlled trials, placebo-controlled, that have shown some results, and it's very interesting. They are completely opposite of each other in terms of the outcomes. So let's start off with the first trial that broke. This was a trial that came out of China, randomized double-blind placebo-controlled trial in about 250 patients. The primary outcome that they were looking at was time to clinical improvement within 28 days. They had a bunch of secondary outcomes, and those included all-cause mortality, frequency of invasive mechanical and ventilation, duration of oxygen therapy, hospital admission duration, et cetera. So a bunch of things they were looking at. Bottom line here was that when they looked at all of their outcomes, primary or secondary, there was no difference between the Remdesivir group and the placebo group. So their trial was very much negative, saying that there was no benefit to Remdesivir. Now, there are a couple of key limitations to this study. First is that patients received other antiviral therapy as part of the study, and that included lopinavir, ritonavir, interferon therapy, and corticosteroids. So in theory, those were equally balanced amongst the groups, but it's a confounding factor. Some other limitations with it, there were some statistically significant differences in some of the groups. So in the Remdesivir arm, there were more patients with comorbidities, including hypertension, diabetes, and coronary artery disease as compared to the placebo arm. There were more patients who had a respiratory rate of greater than 24 breaths per minute in the Remdesivir arm. And then in the control arm, there were more patients who had been symptomatic for 10 days or less. So all of those favor the control, all of those differences favor the control arm. So it may be that we're not seeing accurate results. So that was the first study, some potential issues there. So the next study that came out was a study that was coordinated by the National Institute of Allergy and Infectious Disease, part of NIH. And that was a study in 1,000 patients, more than 1,000 patients. And we don't have the full data yet. So this is sort of an abstract form. And there we found very positive results. So the preliminary results there found a 31% improvement in time to recovery. So 11 days in the Remdesivir arm as compared to 15 days in the placebo arm. That was statistically significant. And there's also a survival benefit, at least suggested survival benefit. It just misses being statistically significant. So in the Remdesivir arm, the mortality rate was 8% as compared to 11.6% in the placebo arm. And the p-value there was 0.05. So again, it just missed being statistically significant. These were preliminary results for this trial. So as they continue to accrue patients, my guess is that as the sample size improves, that will actually become statistically significant. So there's our Remdesivir update. It does look like there may be some activity of Remdesivir in, at least certainly in the largest randomized placebo-controlled trial to date.
Great, that's great information. And as you all will see later, We do have additional information available for you at the COVID-19 webpage on Pharmacists.com, and we'll share some details about that a bit later. Now, Laura Hall is on the line and has asked a question, but she doesn't have a microphone, so I'm going to just address this one. She's asked, can you please explain what is the setup for a pharmacy that is going to do COVID testing? Laura, I am so glad that you asked this question, because COVID testing is something that has been a hot topic in the pharmacy community. As you all know, the Department of Health and Human Services issued guidance on pharmacist ordering and conducting of COVID-19 tests. And on last week's live program, we had a pharmacist from East Tennessee who shared her experiences as one of the first pharmacists in the country to offer COVID-19 testing in her community pharmacy. So I'll guide our listeners back to last week's webinar, and she shared with us lots of great tips on how to appropriately set up your pharmacy to do COVID-19 testing. And in addition to that, a plethora of information is available at Pharmacists.com and the COVID-19 resource page to help you with that particular issue. Now, I want to open the line of Arpana DeBroy, D-E-B-R-O-Y, who has a question about disinfecting masks for reuse. Okay, well, the question here, and I guess Dan will take this one from you. Which spray disinfectant is recommended to use on masks that we want to reuse? Should we use isopropyl alcohol, diluted bleach? Is there some other method for disinfecting masks that you'd recommend? Dan, what's the guidance that we've gotten here from CDC on this topic?
All right, so this is another question that we get frequently, and the bottom line is right now, in terms of spray disinfectants, there's really not a spray disinfectant that's recommended. Lysol, bleach, isopropyl alcohol, none of that would be recommended. The best available information right now is looking at ultraviolet light. There's some other data that is looking at vaporous hydrogen peroxide. So there's a number of systems that create a hydrogen peroxide vapor. So to be clear, we're not talking about dipping masks into hydrogen peroxide directly. And then the last is moist heat with a very specific set of criteria for time and temperature exposure that needs to be maintained in order to sterilize a mask. So those are the best information that we have. There is some information on the CDC website about using hydrogen peroxide, liquid hydrogen peroxide with a 1 and 30-second exposure. There's not a lot of information about exactly how that was done. And so also there's some limited testing available, so it's not fully vetted. So a little bit of a complicated question with that. So there really isn't a best practice for home users at this point. The other thing I will also add that I'm realizing as I'm answering the question, I'm assuming we're talking about an N95 respirator here. If we're talking about a different type of mask, everything I said is specifically geared towards talking about N95 respirators, not other types of masks like cloth masks or traditional surgical masks, things like that. So one big caveat that I need to add.
Great. Well, thanks, Dan, for that answer. Now, I want to ask one last question of our folks from the FDA. We've gotten several questions today from multiple different people talking about compounding of hand sanitizer. And so I'm going to ask both of these questions. They're really two different trains of thought. But Gail, if you and your team could just give us a quick word about this. First of all, we've got a hospital that wanted to compound hand sanitizer, but the hospital ran into some issues with flammability. How are people getting around this issue of flammability and compounding of hand sanitizer? So that's one issue. The other issue is that the media and consumer media particularly have done lots of stories about home-based compounding and home-based formulas for creating your own hand sanitizer. And as you all probably know, pharmacists get asked a lot of questions at the consumer level. You know, can you combine alcohol with, for example, aloe vera gel or other things at home and produce hand sanitizer? So not that the pharmacist would do that, but do you have any thoughts, or does FDA have any comment about that kind of home-based production of hand sanitizer in this issue that we're in? So 2 questions: hospitals and flammability. Secondly, consumers and making their own hand sanitizer. Gail, what's your team's thoughts on those 2 things?
Am I unmuted?
I can
Can you
hear
hear
you.
me?
We can hear
Okay,
you.
great. I don't have any information. I haven't heard about the flammability. You know, again, I probably would have, if I were the inquirer, I'd ask through the COVID-19 mailbox to get some information on that. With respect to the home-based hand sanitizers, we have issued guidance that, as you know, we talked about it. This guidance allows for the compounding by, you know, state licensed pharmacists and outsourcers to make the hand sanitizers, because we think they are best suited to make them. I mean, there have been reports of in the news of people making their own home-based hand sanitizers and those causing some, you know, adverse events. So I think it's better for, you know, we say it in the guidance that, you know, we're aware of reports that the consumers are producing these hand sanitizers, and we don't have any information on the methods that they're, you know, using to prepare these products, or whether they're safe for use on human skin. And we know that, you know, compounders can make this product, and they can make it correctly. So we would refer to the guidance where we state that the, you know, the compounders are in the best position to make these, you know, alcohol-based hand sanitizer products. I don't know if Ian or Dave, you've heard anything about flammability of hand sanitizers. I haven't heard anything. Doesn't mean it doesn't exist. It's just I haven't heard that issue being raised before.
This is Ian. Just a question. Have there been noted cases of small fires within pharmacies because of it? I mean, it's a flammable liquid. There's certainly no open flames and ungrounded equipment.
Ian, this is not something that
I'm not aware of. This is the first report of or concern about the flammability.
Yes, so I think that if there's more questions on this, we should have the inquirer direct them to the COVID-19 mailbox, and they probably could get a response on that regarding flammability.
That's great. So let's move along. We're running short on time. I've got a couple things I need to cover. I want to thank our FDA folks for joining us today. Let's just move ahead to the next slide, please, staff. Just to make you aware, there is a 15-minute CE on, as part of APHA's 15 on COVID-19, giving you a deeper dive into the viral properties of COVID-19 and Remdesivir's mechanism and how it's working. Would encourage you to take a look at that, and also a new episode coming related to zinc and its use in COVID-19. As we move on to the next slide, just sharing with you that an increasing number of states are now authorizing pharmacists to do COVID-19 testing based on HHS guidance. This is a picture of New York's governor making that declaration, and there are quite a number of states who have done that. And we would just guide you toward the resources at pharmacists.com, and also the National Association of State Pharmacy Associations, or NASPA, has a very good resource available on their site, which you can access through pharmacists.com as well. Next slide. We do have a call to action for all of you on the call today. Please, please, please share this on your social media. Encourage consumers, not just pharmacists, that it is time to tell Congress to get pharmacists in the fight for COVID-19 and influenza. There will be a bill voted on in emergency legislation within the next couple of weeks, perhaps even within the next few days, to authorize pharmacists to be paid under Medicare Part B to test patients for COVID-19 and influenza, and we need your help. Go to actioncenter.pharmacists.com. It takes less than 2 minutes for you to fill out your support that will go directly to your senators and to your congressperson, letting them know that you want them to pass this legislation. And I would encourage you to share this broadly with consumers as well, to get them involved in helping us obtain this authority. Next slide, please. You also check out our new practice resources. We have several of those that are available. I won't get into the details of those today, but there is one new one on vaccines in development for COVID-19. We had some questions on that today, and although we didn't have time to get to those, do know that we do have a resource available to you online about those vaccines that are under development. Now, our next slide. There are also clinical links, and we'll proceed on to the next slide, please. Again, I want to mention to you the Engage platform. It's not only the questions that you give us during these webinars, but we monitor your questions throughout the week, and we want you to share your experiences on Engage of what you are seeing happen on the front lines in pharmacy related to COVID-19. The more information that we can share with each other, the better care we can provide to our patients, and we will certainly address issues that frequently come up on Engage during our weekly webinar series that we have. Now, I do want to tell you that next week we're very excited that we will be having as our guests 2 pharmacists who are on the front lines, one a hospital pharmacist and one a community pharmacist, who will be sharing their stories about experiences with COVID-19 and some of the lessons that they've learned, which hopefully will assist each and every one of us in doing our best to provide care for our patients during this pandemic. Thank you all for joining us again today. We will be back next week, the same time and the same place. Be safe and God bless.